My first experience of death was my grandfather on my mum's side when I was a young child. And what I really remember about that is the funeral, I think. My grandfather was a shire president in the country, in Gippsland. He was a very well-known figure, I'd say, as a farmer and as a kind of semi-industrialist in some ways. And so what I remember about the funeral was huge. It was at a local country church, and there was just people spilling out from the church. I think it was a little bit sort of confusing, I think, for me to understand why people were there and what was happening. I can't actually remember how old I was. The family members that I know who've died have all been towards the end of their life, so more elderly. So I think that the sort of, really emotionally jarring deaths that I've been involved with have been children and patients that I've cared for. My emotional reactions to the death of grandparents have been, one of sadness and loss, but also celebration of their lives. A couple of my grandparents have lived colourful lives, and so to reflect back on their lives and what they achieved and who they were and their legacy and what they meant to me. And I think, often for your grandparents, your really strong memories of them are, when you're a child and you're staying with them to give your parents a break from you, remembering those special times. I do think that one area that, at least the training that I've had and, the experience, is to be quite clear with language. I don't think it's helpful for the patient, the family, the staff involved to dilly-dally around the words, I think. And in fact, it's the opposite. I think being quite clear in language puts everybody on the same page. It's particularly important in particular circumstances. So for example, if a doctor is asked to certify a patient, whether they're dead or not, and the family wish to be in the room when that's done, it's really important to be very clear and to use the words dead, death, died, because otherwise it's unclear for the caregivers. So I do think that's something that's changed, and maybe that sort of points to an inflection point in the way doctors are taught and trained around death. My experience of death in children is kind of in a couple of different ways. The kind of most positive experience of a death of a child for me, and there's a couple of memorable children for me who died, is where there's a relationship with the child and the family over a longer period of time. So they are usually, children with chronic illnesses, and there's time to anticipate and plan and discuss with the family and the child, if appropriate, depending upon the age of the child, about what that death will look like, how it will feel, what can be done in advance and what can be done afterwards as well. I've also been involved in the caring for children who died unexpectedly. So a previously well child who comes into hospital as a result of an infection or trauma and dies suddenly. So they're quite different actually. Both have challenges, but certainly the unexpected death of a child is quite shocking, I think. There's just not that opportunity to prepare for the death of a child. And so as a senior doctor, it's quite different the way you deal with those two scenarios. There are also, as a doctor, just practical things that you have to do. There are tasks for you to do as a doctor. I think it's the role of the senior doctors to do that are just, jobs that we have to do. So, communicating with the coroner, thinking about whether an autopsy is appropriate, thinking about what tests might be done before the death of a child, and then thinking about the support of the family, and that the definition of family is quite different depending upon circumstances. Understanding the sort of cultural milieu that the child's in, because that can change as well, what happens after the death. Certifying a death, which can be quite an intimidating experience, and then planning for what happens after the death, and making sure that there are memories and keepsakes for the family after a death as well, and then planning to, if possible, meet up with the family at an appropriate time afterwards. As a senior doctor, there's the kind of practical things that we have to do, that we need to just remember to do, which can be difficult in the time. That's our job. And I think there's also a job as a senior doctor to teach the junior doctors as well about what those things are and how they're done. Then there's the support of the family, and then the support of the staff. So it's the nursing staff that are involved, the allied healthcare staff, social workers, the junior medical staff. And that support role can be done in a few different ways. But one of the things for me is having a forum where people can meet up and talk. And that forum can be one-on-one, which might be appropriate, or can be in a sort of a larger group. And the other part of that, I think, is just thinking about just being alert to sort of any signs in staff that you work with that might be concerning. And also being aware of what reactions might be for different people, and there's quite a big spectrum of what those reactions are. And then the final thing is just, monitoring your own reactions as well. I remember the first death of a child I was involved with, which was in a neonatal unit as a registrar, and it was a premature baby who was probably expected not to survive. And my response surprised me, actually. I found myself having to take myself out of the unit for 10 minutes, and I was just sobbing my eyes out and it took me a while to understand, what I was feeling and why I was feeling that. In paediatrics, we have the great fortune that children are remarkably resilient, and hospitals are in generally a positive place where children come to hospital, they're treated, they get better, and they go back to their families. There is this sense of, as medical staff, that we make people better. When we don't make people better and they die, it's an unusual experience, and so that's a really jarring aspect, I think. And I think it is changing for doctors coming through, but that kind of sense of if your patient died, you failed, which is obviously not always the case. In many cases, for children who have, a chronic illness or an oncological condition where we've done everything we possibly can, death may not actually be the worst outcome. It might be the best outcome for that child. And so it's, reframing that kind of sense of, if a patient died, we failed, is to, think about that in a different way at the appropriate time. I think it is probably different for, I can't speak too much to this, for, say, an adult intensive care doctor, where, a high proportion of their patients will die and they're dealing with death every day. It's different. It's different for those doctors it is for me, for example, as a paediatrician, where death is relatively uncommon. So I think it's important to make that distinction. In our training and recognition of what it's like for you to grieve, what you're going through, and resources for you to tap into for support, I think is really important. Whether that's online resources, something as simple as that, or seeing somebody you can speak to about that. But having the awareness to recognise that in yourself, I think, is really important. And the second part of that is that, in some ways, being involved in a good death kind of like takes away from that, because a good death can be, a positive experience in some ways. If things are done well, it's a very intense relationship with families and with a child as well. But if families are supported, understood, are able to take the lead in how death happens, also a good sort of follow-up as well with doctors. And one of the things for doctors is also attending funerals as well. Sort of to come back to our first part of the conversation around, my grandfather's death and being at the funeral and being a bit confused. I think actually being at a funeral or memorial is actually really important, to sort of be able to see the child and the family in the context of their community, to sort of be able to draw things together is actually really important to get a little bit of closure, I suppose. Palliative care was probably in its infancy at that stage. Don't want to age myself too much, but certainly things have changed. I'm not really across what might be in the medical curriculum at the moment around dealing with death, and what's in the medical curriculum around dealing with your own grief as well around the death of patients. But I guess what I can say is that where I work, and in many or all tertiary quaternary paediatric hospitals, having a palliative care service does make a big difference. And the palliative care team are incredibly important in both the sort of unexpected death but also the planned and expected death of a child. Having said that though, you know, for the patients of mine who were my long-term patients and there was we were planning for a death, the palliative care team are involved, but I'm still being the primary carer for the patient and their family, and so that relationship doesn't change. In terms of medical curriculum and training, in many ways I've probably learnt on the job, I think, along the way, but having the support of a palliative care team, bereavement team that you can draw upon for resources and a shared approach is obviously really valuable. Even though as a senior paediatrician death is not common in hospital, it still occurs, and we obviously care for the patients who have most complex conditions at our hospital, and I think every doctor should be equipped with skills, understand theory around palliative care, the aspects of palliative care, and understand, but also have an understanding of the grieving process, I think, and how it impacts on others but also yourself. I think that's really important, because I think the death of a patient, if it's not well managed or it affects somebody in a particular way and that's not acknowledged and you're not supported, that can lead to really adverse outcomes for individuals. Training around grieving and the grieving process and how it affects you is actually really important, and it being quite explicit and out there in the medical curriculum. There are so many factors that come into that, and that's where conflict can occur, I think, with families and caregivers, where either the family feel that it's time to stop but the doctors don't, or the flip side. And I'd probably say that sometimes it's actually the flip side, where the medical staff are kind of thinking, we've done as much as we can, we should start to reframe the way we're thinking about our management and treatment goals, whereas families may not be ready for that. And so I think that's a real skill, actually, and I think that there's an art there around not convincing a family, because it's not about convincing, it's about having conversations that might take some time to come to a shared understanding about where we want to go and what we want to do here with the patient. My sense in general for children is that there's not too much over-medicalisation. I think that some of the best deaths that I've been involved with has been where we've been really clear about getting the child home, because I think dying at home is, in general, not always, it's a much more positive experience than dying in a hospital. That's not always possible for various reasons related to treatment and so on, and so there are some things that we are able to do within the hospital walls to make it feel as little medical as possible. Like I said, particularly with unexpected deaths, that's not often possible, but for planned deaths, I think really taking the medicine out of it and getting the patient home and having the patient with the family at home is, should be the goal as much as possible. In my family, talking about death is quite an open discussion, I think. Death is a part of life, that kind of thinking. And then in my sort of medical practice as a paediatrician, so all of the deaths that I've been involved with as a doctor that I remember are of children. The death of a child, I think, is not a common occurrence, at least in Australia. Some other places where I work it's more common. And the death of a child is a tragedy, of course. But my experience, I think, of children dying as a doctor has mostly been as a senior doctor and taking on a role of, I guess, supporting others and trying to be open, trying to share grief, and people grieve and respond in different ways, being open to people responding in different ways. So from that perspective, as tragic as the death of a child is, I think for me personally, it has impacted on my view of death and a good death. As a health leader, I think in terms of our public understanding of death, what I'd like to see is I guess, more open discussion, appreciation of different cultural viewpoints, I think. I think there's a lot to learn, and I'd once again emphasise and highlight the Indigenous view of death as well. I guess I bring my own views to it in a way, which is, death is part of life, with my particular spiritual or non-spiritual view of death. I see death as something that's, I guess, to be embraced in some way. The kind of Australian view of death, it's incredibly diverse, isn't it, really? To come back to the practical, there are practical considerations around deaths of people who are in different cultural groups, right? Around timing of a funeral, how to deal with remains. Like that is inherently interesting, but also really important that we as doctors and as medical nursing staff, as hospital staff, have a cultural awareness and understanding of that, I think. On the spirituality side, cultural factors and spirituality sort of, mix in here. Yeah, I think being aware of the kind of spiritual viewpoint of the family and patient that you're dealing with is really important, particularly for both planned and unexpected deaths. But that should really be a part of how you plan for a death, is, how all those things, what the family want, how they view things. And that's where, it's really important to listen to the family, but also to listen to whomever they want to have involved in those discussions, whether it's cultural liaison officers or priests or whoever it might be. So I personally find that really interesting. Personally, I'm an atheist, and I think this life is a life that we lead. So I've got my own sort of views, which maybe are sort of more mainstream Australian, I suppose. But I think it's really important for a positive death that, you really think carefully about those aspects. Death to different cultural groups is very different. The way it's viewed, the way it's conceptualised. And so you do have to be really careful not to bring your own preconceived concepts, I think. Increased cultural awareness, particularly around death, I think from an Indigenous perspective, is something I'd personally like to see more of in the medical training, both at medical school and after that, because I do think that that's a unique way of conceptualising life and death, isn't it, among Indigenous groups in Australia. I 100% agree with that. So I think it's important that the public are given information. And the way we started was, number of cases per day, and now we're in a situation where number of cases per day is kind of irrelevant, really, because a lot of people are not getting PCR tests, or if they are doing tests, they're doing rapid tests at home and not reporting them. Some might report them, or some people are just not testing. So we've moved more towards hospitalisations and deaths. Hospitalisations is a bit problematic because we don't really know whether a patient's been admitted for COVID or with COVID, and if it's with COVID, what's contributed to their admission. And then deaths, I think, is also problematic as well. I think we need to sort of start to rethink about our strategies around COVID. We need to sort of become a bit more sophisticated, and that includes the way we think about deaths, I think. In whom are those deaths occurring, particularly what age groups? There's a whole another conversation about vaccination status and so on, but I'll leave that to the side. That, I think, is important to start thinking about our public health policy as well. So rather than talking about number of deaths per day, we should be thinking about how do we reduce the number of deaths in particular groups. Because saying that we're going to put everybody in masks or vaccinate children or go back into lockdown, which I know is not going to happen, to prevent those deaths, that's a blunt tool. So we need to sort of think a bit more about in whom and where those deaths are occurring, so we can maybe sharpen our public health policy. I think being involved at a sort of senior level in the death of a number of patients has helped me to, every now and then in the care of a patient, take a breath and step back, and maybe, you're sort of in the thick of a very complex patient where there's multiple medications and treatments and escalating care, to sort of turn to a junior doctor and say, where are we heading here? Let's just take a moment to think about the bigger picture. And maybe that conversation is, well, actually, if we do this, this and this, these three things, we're going to be in a better position for the care of the patient than we were before, and we expect a full recovery, for example. Or it might be, actually, we're escalating care here in a way that might lead to more iatrogenic or complications in hospital. It's maybe not in the best interests of the patient, and maybe it's a time to think about conversations with the family. So it's just, I guess, that kind of seeing a patient's life through to the end, being involved, and recognising that for some patients a good death may be the best outcome for the patient and the family. Being able to pass on that experience or wisdom to a junior doctor and be able to sort of just take that breath and sort of stop and say, let's think about the big picture, let's think about what the family want, what the patient wants, and whether we're going in the right direction, whether we need to reconsider our treatment goals. Yeah, that's been incredibly valuable to me, I think. I think my personal experience of death relevant to my patients has kind of accumulated through my clinical practice rather than necessarily family experience, I think. I mean, one thing I will say about paediatrics is that by its very nature, so we view the child with their own rights as an individual very strongly, but I think maybe more than some other branches of medicine, we also view the child within their family and then within their community. So we kind of, I think, bring that broader view already, and I think paediatricians in some ways already bring, I feel, quite a sort of holistic view of the child, I think, and so are more open to a way of thinking or discussions that go beyond just the biomedical view, I think. No doubt we do get caught up in the biomedical aspects and the new treatments and what is the randomised control trials, and they're all things that we should do, like that's our job. Our job is to know the evidence and provide the best treatments for the patient. But I do think my experience, and maybe I've got a biased view, but my experience is that we do at least try our hardest to bring those treatment options within a broader context, I think. I'm not saying that we do it perfectly all the time, because that's definitely not the case. And I think there's definitely scope for more of that, broader view. But I do think we're at least starting from a good point. But I wanted to sort of get across that point of, the practical stuff that we have to do as part of our job. There's a little bit of it's not a checklist, but I'm always thinking about, what's my job here, as well as supporting others and thinking about your own sense of, how you're doing as well as an individual.